Good morning and welcome to everybody that's joining us for the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. For those of you just coming into the webinar, thank you for joining us. This is going to be kind of a fun day today. This is Card P Day. Card P is the Canadian Academy of Restorative Dentistry and Prosthodontics. This organization that's helped us put together these webinars over these weeks has lined up the 4 speakers for today. So pretty exciting. Our first speaker is Dr. Mark Douglas from Toronto. So we're going to start off with Dr. Douglas, followed by Dr. Kim Parlett, and then we're going to end with Dr. Ian Tester. For those of you that are new to Zoom, take a look at the interface. You can change your settings there. You can change how big the presenter view is on your side. You can change the size of the slides, what you're seeing in terms of the panelists, the speaker, whatever. You're not going to hurt this interface. If you get knocked off, just log back in. That's not going to be a problem at all. We're not going to use the hands up feature, and we're not going to use the chat window. If you move your mouse around, you'll find that there's a chat feature. If you click on the chat feature, Dr. Gary Hayamoto will be putting information in there periodically. If you have some comments, feel free to put them in there. If you actually have a question for Dr. Douglas, let's put that in the Q&A section. I'd ask you, if you're going to ask a question and you go into that Q&A tab, take a look first if your question is already being put in there, and just upvote that. The thumbs up will move it to the top, and when we get to the end, depending on how much time we have, we'll deal with as many questions as we possibly can. The Washington Academy of General Dentistry Stay Home, Stay Healthy CE series is sponsored by the University of Washington School of Dentistry CE Department. You will be receiving CE credits from the University of Washington. Those credits will come probably 2 to 3 days from now. They will come in the form of a PDF. That PDF is not personalized. Just take that PDF, put your name on there, and save it for your records just in case there's any issues down the road. Academy of General Dentistry members, we will report your CE credits directly to the Academy of General Dentistry, and that will show up on your AGD transcript probably within 2 to 4 weeks. So be patient with that. There's lots of upcoming webinars. We still have 2 days worth this week. We do not have all our webinars up for next week. We're finalizing the details for that. We have some great offerings. We're going to include suicide training and also the opioid training that's mandatory here in Washington State. So that's something that once we get that registration up and running, you'll want to get signed up for. Where can you find the registration links? Well, you can go to Facebook. You can also go to washingtonagd.org and also be on the lookout in your email box, because we are going to be sending those out as well. We're just trying to finalize the flyers, registration links, etc. But it looks like we're actually going to have a full lineup of webinars again next week. So it's fantastic, all the speakers that have volunteered their time and their content to help us out. We really appreciate that. We'd like to thank our co-sponsors, Comet USA, Patterson Dental, Pierce County Dental Society, Seattle King County Dental Society, and Snohomish County Dental Society. Thank you for your support, for your emails, your Facebook posts through this pandemic. We appreciate it. We'd like to thank the International Academy of Nathology for putting together the speakers on Monday. We'd like to thank Arkansas AGD for putting together the speakers on Tuesday. Just a reminder, if you missed any of the webinars, you can go to YouTube, go to Washington Academy of General Dentistry, and you'll be able to see the webinars on YouTube there. The only downside to watching those webinars after the fact is we cannot issue you CE credit. In the future, the Washington Academy of General Dentistry will have an on-demand site on our washingtonagd.org, and you should be looking for that probably in the next couple of months. We're working on that to be able to bring you on-demand CE in the future, where you can actually register, watch CE, and get credit for that. We'd like to thank the Canadian Academy of General Dentistry, all the members up there that are watching us today. Welcome to our University of Washington School of Dentistry, AGD student chapter members. Thank you for joining us. WashingtonAGD.org, that's where you can find more information about upcoming classes at our educational center here in Seattle. We have an educational center that's right down by the airport, easy to get in and out. That's where we offer hands-on courses, and those hands-on courses, we have a variety where you can just sign up for a course here and there, and we also have our Master Track program, which is a tremendous program that we have 4 sessions, 28 hours per session of CE credit. So check that out. It's really cost effective if you're an AGD member. Well, I am going to stop sharing my screen here. I'm going to welcome our first speaker from the Canadian Academy of Restorative Dentistry and Prosthodontics, Dr. Mark Douglas. Welcome. Thank you for joining.
Thank you, Tim. Thank you, Tim. And
just before we get started, could I read your
Sure.
bio?
Sure.
All righty. Mark Douglas graduated from the University of Toronto Faculty of Dentistry in 1991, following the completion of a master's degree in physiology from Queen's University. He maintains a private practice in West Toronto, where he has practiced for 28 years. Since graduating, he has been active in organized dentistry, serving on the Ontario Dental Association General Council and Education Core Committee, as well as president of the West Toronto Dental Society and the Toronto Crown and Bridge Study Club. Welcome, Dr. Douglas.
Thank you, Tim. How are you today?
Great. Now, am I to understand you're a new Card P member?
I've only been a member for last 2 years.
Okay, well, welcome. And as you know, I'm a Card P member, even though I live down here in the States. Great organization. It's a shame that the meeting has to be canceled in Halifax this year, but
It is.
yeah. All righty. Why don't you go ahead and share your screen? Do you need anything else from me?
I think I'm good here. I'm going to start the screen share, and we'll go and play. All right, is that all up and ready?
That looks good on our side. I'm going to mute myself. And again, thank you very much for your time. We really appreciate you volunteering this lecture for us.
Well, it's my pleasure, and I want to thank you for the invitation to speak today. I hope I have something to impart to this group. There's been a tremendous slate of speakers that you guys have organized already. And so I want to thank Dr. Hess and Valerie Bartoli for organizing this and putting an extraordinary amount of work into these presentations. What we're going to do is we're looking at immediate implant provisionalization. And what we're going to do is use the extracted tooth to replicate the natural emergence profile. Other people have done things similar to this, and but this is just taking it one step further. So what we're going to do, I'm going to start off with a basic review of the criteria that I'm going to use to determine aesthetics. Now, it's more complicated what I'm doing. It's going to be a very simple thing. We're just looking at gingival margins, and we're not getting into tooth anatomy or smile design or facial features or anything like that. And then what we're going to do is we're going to look at the variables that we need to control in order to achieve success with this. And then we're also going to look at what are the different options we have to temporize an implant that's been placed immediately. And what we're going to also do is I'm going to try and provide the evidence. So everything we do, every step in every procedure should be based on some kind of evidence. And what I'm going to do is I'm going to sort of critically evaluate the literature that that supports the decisions that we have to make. So much of what we do is done empirically, and I'm going to try and see what the literature shows as far as the rest of this, as far as the presentation is concerned and the steps that we're taking. So what we're looking at here is an ideal smile. And it used to be considered success just for an implant to become integrated before it was restored. And this is an example of an implant in the upper right lateral position that is integrated, but I don't think that we can really call this a success. It's a failure aesthetically. It's also a failure functionally because it's losing buccal bone. And so surgical and prosthetic knowledge and techniques have now developed to a point where we should be able to restore an implant that blends with the natural dentition. So what factors are we going to look for in an ideal smile? So this is Jessica Alba, and she has pretty much the perfect smile as far as I'm concerned, and I think many people would agree with that. What we're looking at here is the gingival margins should follow the contour of the upper lip, and right along there. And the incisal edges should follow the contour of the lower lip. Plain and simple. And this is one we're going to spend a lot of time with here, is the gingival margins of the central incisors and the canines should fall along a straight line. The lateral incisors can be on that line or about 1 millimeter coronal to it. Our biggest concerns are recession, gingival recession and bone loss, and loss of papilla. Right there. And in the posterior, gingival recession and bone loss, and also loss of papillas. This is an area that's prone to food trapping. These type of situations is really what got me interested in exploring ways that I could improve the outcome of implants like this. So back in 2001, John Coyce wrote an article, Predictable Single Tooth Peri-Implant Aesthetics, 5 Diagnostic Keys. And this article has been cited numerous times. And so what are the 5 diagnostic keys? They are relative tooth position, form of the periodontium, biotype of the periodontium, tooth shape, and the position of the osseous crest. And we're going to go through each of these individually. Relative tooth position. Got to look at that in 3 dimensions: apicocoronally, buccolingually, and mesiodistally. Apicoronically, or vertically, what we know is that you will get 2 millimeters recession following extraction and pontic site development. If you do nothing, just take the tooth out and maybe put a bone graft in there if you have to, and put a temporary denture in, you will get 2 millimeters of recession. If you place an immediate implant, you will only get 1 millimeter recession. If the free gingival margin is coronal to ideal, as it is in this case here, see how it's a shorter tooth, you got a little bit of dental-alveolar extrusion around this tooth, that's ideal because when you get the 1 millimeter of recession around that, it should bring it back to closer to normal. If the free gingival margin is apical to normal, then what you want to do is you need to do some orthodontic forced eruption. You got to get the bone and the soft tissues back into the proper position before you put your implant in. And so this is a case we did years ago where we actually just replaced the crowns. He had some pocketing around the upper left central incisor, 8 millimeters. And as we'll see later, Coyce turns this low crest. Take a look at the radiograph in the middle. You can see how much bone loss there. There's a very poor crown to root ratio. So prior to placing our implant, what we did was we put some brackets on and we took this tooth and we slowly erupted it about 1 millimeter per month. And if you see in the picture on the right, the free gingival margin hasn't moved an awful lot yet, and you can see how much of the crown we've taken apart, and the wire is still up there. So what's going to happen is as we continue with this, the first thing that happens is the sulcus inverts itself, and then the periodontal ligament fibers will pull the bone down. You have to do this slowly. You cannot do this quickly. Like I said, it's about 1 millimeter a month, and you have to hold it there for about 4 millimeters afterwards. And in this way, if you get the bone to the right place, the implant can be put in the proper position, and you can develop your margins properly. So now this is on the left side, this is what we started with. And this is our final radiograph in the middle. And you can see that we were able to bring our free gingival margin down to be about equal distance with the adjacent central incisor. So if we look at buccolingual dimension, if a tooth is buccally inclined as it is in the upper right lateral incisor here, what happens is the gingiva tends to go more apical, and you have very thin or no buccal bone. So these are very, very prone to vertical and facial collapse of the bone and gingiva after you take the tooth out and put an implant in. So the way to deal with this is you really want to do some grafting, either before and or after the extraction. On to the next one. If it is lingual, as it is here, the same tooth is now lingual, you notice that the gingiva tends to be more coronal, and there's your reference for that. You get thicker bone and gingiva on the buccal. The trade-off with that is you have no root prominence. And if we look at the mesial distal dimension, if the teeth are inclined, you wind up with a larger gingival embrasure and a higher contact point right here. And so this is much more difficult to fill with papilla. So the greater volume, the greater volume, because the roots are spread more up here, there's a greater volume of interproximal bone, which leaves that less prone to recession. And so the form of the periodontium is the next of the 5 diagnostic keys. And he divides those into flat scallop, which is 85%, and high scallop, which is about 15% of the population. Normal is around 4 to 5 millimeters. And we're going to go into the scallop. So, Bill Robbins discussed this 2 days ago and did a fantastic job, much better than I could ever do. So the normal scallop is about 4.5 millimeters from the tip of the papilla to the gingival crest. And this was based on Coyce's study where they looked at a survey of about 100 patients. And so they divided that into a flat scallop or a high scallop situation. Now, if you look at why does this happen? If we look at what happens with the bone around the teeth, the bone has a natural scallop around it, and that follows the CEJ of the tooth. That scallop is from the height of the interproximal bone to the height of the buccal osseous crest, and it's about 3 to 3.5 millimeters. Get back to the diagram. And so height of the interproximal bone to the height of buccal crest of bone is 3 and 3.5 millimeters. The osseous scallop, it parallels the CEJ circumferentially and about 2 millimeters apical to it. Again, Bill Robbins was discussing this yesterday or 2 days ago when he talked about sometimes if they have what's called low crest, you need to go 3 millimeters, but I'm not going to confuse the issue right now with that. So a flat gingival scallop is only about 3 to 3.5 millimeters. And what it does is the gingival tissues approximate the biologic width around the tooth. It mirrors the osseous scallop. These type of patients, they're very resistant to recession. A normal or a high gingival scallop is between 4 and 5 millimeters, with the bone scallop, the osseous scallop remaining about the same. So there's much more gingival tissue coronal to the interproximal bone. The connective tissue attachment and the epithelia attachment are constant at about 1 millimeter each, unless you're into a long junctional epithelium, which Bill Robbins described as low crest stable. The sulcus depth interproximally, where the papilla is, has to be deeper, because if you don't have 1 millimeter of epithelial, 1 millimeter connective tissue, then to get that 4.5 to 5 millimeters means you got to have a deeper pocket interproximally. And the papilla, it relies on the adjacent teeth to help. You need 2 teeth on either side to help support the papilla. So if you take 1 tooth out and don't replace it, then the papilla will recede to that 3 millimeter type tissue depth. And a medial provisional should have the same embrasure form as the original tooth to help maintain the papilla. So it needs support from it. So it should be symmetrical contours, and you want to maintain symmetry. And so now for the biotype of the periodontium, he divides those into 2 types, thick and thin. The thick resists recession and loss of papilla, and the thin biotype is susceptible to recession and loss of papilla. As far as tooth shape is concerned, there are 3 types. There's square, ovoid, and tapered. The square biotype has a smaller gingival embrasure, which resists loss of papilla. The other form is the tapered, which has a larger gingival embrasure, and it's much more susceptible to loss of papilla. As far as the square type is concerned, because the tooth is so wide, the interproximal bone is thinner than it is in the tapered situation, which means there's an increased risk of vertical bone loss. As compared to the tapered, with thicker interproximal bone, there's more bone in between those. It's much less susceptible to interproximal bone loss. And the final one is position the osseous crest. Now, John Coyce developed this concept. Bill Robbins talked about it 2 days ago. This article here was published in 2007, in which he outlines the differing types of position for the osseous crest. And what you need to do here is you need to take your periodontal probe and you need to freeze the patient, and you need to sound down to bone. Then you're gonna take a measurement from the bone to the gingival crest. If that measurement is 3 millimeters, and it's always 3 millimeters in these people, right on the buccal, the midfacial, then they are classified as normal crest. And interproximally, they'll be between 3 and 4.5 millimeters. That's normal. And you will get about, when you take a tooth out and place an implant, immediately you will get up to 1 millimeter loss of the dental-gingival complex. If you look at the, let's do the low crest next, is this situation, which is the one where we did some forced eruption a few slides ago. These people, when you sound down to bone, you will get a number that is larger than 3 millimeters. And in between the teeth at the papilla, you will get a measurement that's about 4.5 millimeters. And so the problem with these guys is when you take a tooth out and don't do anything, that the gingival complex will recede such that it's back to this normal 3 millimeters. So you will get recession. So the treatment for that is orthodontic forced eruption, if you can, because I've got a case here I'll show you today where that was not possible. And on the other end of the spectrum, we have just 2% of the population are high crest. These are the patients who are prone to biologic width variables, if biologic width violation. If you place a crown margin at the level of the gingiva within 2.5 millimeters of the bone, you'll wind up with chronic inflammation. And so with these patients, if you get up to about 1 millimeter loss of that dentogingival complex, that may, if the bone goes down and back to the normal level, then you would have harmonious gingival margins when you're finished with your final restoration. So summarizing, of the 5 diagnostic keys, the risk of recession and papilla loss is with relative tooth position. If the tooth is too apical or buccal, then you have a risk of recession. With these next 3, they're all sort of related. You have the high scallop, the thin biotype, and a triangular shaped tooth. They're at higher risk of recession. And the people with a low osseous crest are at higher risk of recession. So how do we control these diagnostic keys? As far as relative tooth position is concerned, if it's apical, you want orthodontic slow force eruption. If it's buccal, you want grafting prior to or after extraction. If it's lingual, you don't need to do anything other than maybe grafting to build up the buccal bone and to create a root prominence. If they're tipped mesial distally, you can do orthodontic to create parallel roots. If the tooth is being extracted, it's the one that's crooked, you don't have to really do anything. But if the contralateral tooth is tipped, then you need to orthodontically upright the roots. Form the periodontium. If it's a thin scallop type, you want to make sure that you do your extractions flaplessly, and you want to put an immediate provisional in there to support the papilla. The biotype of the periodontium. If you have a thin biotype, again, you want flapless extraction and immediate support of the papilla. Tooth shape. If it's coronal to the free gingival margin, you want to mimic the contralateral tooth. That's just for your aesthetics. Apical to the free gingival margin, you want to provide just enough volume that's going to support the gingiva and the papilla, but not apply excessive pressure. As far as the osseous crest is concerned, if it's low crest, you want to do some orthodontic slow force eruption. So how do you preserve the bone? Osseous preservation is entirely surgical and is facilitated by immediate implant placement. So Ken, I believe, did his residency with John Coyce. Gingival margin and papilla preservation. Facial gingival margin position is determined by the position of the osseous crest. The papilla height is determined by the height of the interproximal bone of the adjacent tooth and the gingival embrasure form of the restoration. Maintenance of the papilla is critical at time of tooth removal. If you lose it before you do your final restoration, you have a very slim chance of getting it back. Gingival tissue preservation is governed by the prosthesis. All right, so back to osseous preservation. What do we need to do? We need to extract the tooth atraumatically and flaplessly. Ideally, the implant should be placed immediately. You want 3 to 4 millimeters apical to the desired free gingival margin, 2 millimeters palatably from the buccal osseous crest, so you can pack bone in around there, and also so that your screw access comes out through the cingulum of the final restoration. Ideally, the abutment should exit lingual to the incisal edge for screw retained. The gap should be bone grafted, and the implant should be provisionalized immediately. That helps to seal the defect and helps to contain the bone graft. And you can do this 2 ways. You can do a whole full provisional crown, or you can do a custom healing abutment. We're going to talk about both of those today. As far as the gingival margin and papilla preservation is concerned, it is the gingival tissue preservation is governed by the prosthesis. It should have the same embrasure form that existed prior to extraction. The subgingival contours of the cervical root should also be replicated. The cross-sectional shape of the root should be replicated, and it should have the same coronal shape as the failing tooth. Now, what are our options to temporize? We can make a temporary removable partial denture, an RPD. We can make a temporary fixed bridge, or we can immediately place the implant, and you can temporize that with either a stock healing abutment. You can put a customized healing abutment, which we usually do in the posterior, and you can do a temporary crown, which can be screw retained or cemented. Screw retained is my preferred way to do it. Temporary removable partial denture, we call that a flipper. And with a flipper, you will get osseous and gingival recession, but it'll be 2 millimeters or more because you're not immediately provisionalizing your implant. The problem with these is they exhibit little micro movements, which means the gingival attachments do not form to the denture, which are required to support the papilla. For temporary fixed bridge over here, so you can't always do this. Sometimes you have to bone graft and you cannot immediately place a provisional restoration if there's too much buccal bone loss or there was no bone on the buccal. And so in this case, the tooth was removed, the bone graft was placed, and the tooth was returned to me, and I just bonded it to the 2 adjacent teeth in this case. So you will still get your 2 millimeters of recession because you haven't immediately provisionalized. Hygiene can be a problem with these things because you can get plaque buildup in here, which would lead to gingival hypertrophy. And it's difficult to exactly mimic the gingival embrasure that existed prior to the extraction. So it's tough to get ideal papilla support. And I haven't done the final restoration on this one. She's probably due about now, but we have been off now for 2 months. And the last one here is you can do a temporary crown, either screw retained or cemented. I said before that screw retained is the preferred way to go. It can be anatomic shape, but not necessarily. So you can do these things freehand. It does have tooth-to-tooth contact point. Light is preferred, and it reproduces the gingival embrasure form for us. So 3 ways you can provisionalize here with an immediate implant being placed is you can place a stock healing abutment, which is, there's the implant, and there's your stock healing abutment. So it's round, it's not anatomic. You see it's not the same size or shape as your sulcus is there from the extraction site. It does not support the facial gingival margin. It does not support the interproximal papilla. You cannot do any tissue sculpting with this, and you need to put a temporary PD on top of that for the patient during healing, or a bridge. You can put a customized healing abutment in, which is made by, what you do is when you extract the tooth and place the implant, you put a temporary post into the implant, and then you inject your provisional material into the sulcus. You do this before you place your bone graft, otherwise the bone graft sticks to your temporary. Now it's anatomic in shape, but not always, because the tissues, as soon as you take the tooth out, the tissues will collapse a little bit. And it's also going to be, so it's going to be a little bit smaller, and the shape is mostly freehand, although you're guided by this, but not always. It contains the bone graft. It doesn't reproduce the gingival embrasure form, the papilla, because there's no contact with the adjacent tooth. It's useful if the implant has been placed with insufficient insertion torque, and we use these mostly in the posterior. You can do it in anterior with an RPD on top, but you need either an RPD or a temporary bridge if you're going to do that. Temporary crown, screw retainer cemented. This is a case came to me. The patient was congenitally missing lateral incisors. The implants were placed, and the dentist sold his practice, didn't trust the new dentist to restore them, so the periodontist referred this patient to me. And which is why doing this, it's a bit of a time-consuming thing, but it winds up being a very good practice builder. You send your pictures back to the periodontist when you're finished, and if it looks good, then they will send you more patients to restore in this manner. So getting back to the patient, so now here's what the temporaries look. Those are my temporaries. Let's go back here. So they can be anatomic in shape, but not necessarily. You need an impression of final tooth. Now this one I didn't have that because she came to me late. What we did was I just took a model and fit some denture teeth in there and took an impression of that. So this has, if I go to the model, it has tooth-to-tooth point contact, and you can reproduce the gingival embrasure form, but that's done freehand. The restorations will support the free gingival margin and would help to contain the bone graft. So that's the temporaries, and there we go. So the temporary crown should be placed within the first 48 hours after implant placement in order to maintain gingival margins. There should be no occlusal stops on your temporaries. There should be no excursive contacts on your temporaries. Instruct the patients not to chew on those things, tell them they're decoration only. And the contacts with the adjacent teeth should be very light, if anything. So how do we transition from a round implant platform to an anatomically shaped emergence profile? So the implant's round, the tooth is not. So we need to transition to anatomically shaped emergence profile. So we've got 4 options. These are the 4 options. And the last one is, how do we capture all this information that we've just spent months creating into our final impression and ultimately our final restoration. So we can do a freehand transition, which includes laboratory fabricated. The Harmony abutment, which is a customized healing abutment developed by Richard Aiken. We can use stock shells that Dr. Chu reported on. We can use an extracted tooth, and 4 studies were published on that, the first one being Bob Margis. And we can make a replica of the extracted tooth, which Eric Van Doren initially presented up here in Toronto about 4 or 5 years ago. But he's never really published it. And so at lunchtime during the lecture, we figured out all the different steps with it, and I tried it out, and I'll show you the results. And sometimes when you do that, it's not always, you're not always going to get the gingiva exactly where you want it to be. So the last thing we're going to talk about in these cases is how do you do some tissue sculpting. And finally, customized impression post, so you can capture all the information you just spent all these months developing into your final impression and ultimate restoration. Freehand transition. So Lemongello reported that there's 2 types. You can have them fabricated by the lab, whether it's computer guided or traditionally fabricated with stone and lab components. But the problem with that is it might not address some of the tissue requirements that are presented chairside. The lab is going to take their best guess, but you're going to then have to try and modify that. But if it's made out of zirconia, you're not going to be able to bond to it in order to do that. Or 2, you can do a custom fabricated by the dentist at chairside. This one gives you flexibility with tissue guidance. You can duplicate the emergence profile of the extracted natural tooth. This allows the gingival embrasure form to be supported while maintaining soft tissue contour and guiding tissue healing. You can also control the placement of the restorative margin with cement retained restoration. It's not a problem if you're using screw retain, but you can put your cement margin above the gingival margin if you so desire. You get proper soft tissue guidance support is necessary in the development of natural soft tissue contours and support of the proximal papilla. And surgical healing caps and stock abutments provide a circular rather than an anatomic emergence profile. Those were his statements. And this is how you do it. First thing you want to do is you want to have a matrix of the tooth before you extract the tooth. So here the tooth has actually been extracted, but we had a study model that we took an impression of from before he lost the tooth. You're going to want a temporary post, which you will aerobraid or sandblast. You need an analog, and you need some pinko paker. So there is the patient returned to me just after the implant was placed. I'm going to remove the healing cap. We're going to place our temporary post, and we're going to try our clear matrix in. And this is why you want a clear one, because you can see where the temporary post is, so you know where to drill your hole right there. Then you replace that in the mouth, and you can see that the temporary abutment is coming out through my little access hole. Now you're going to remove it. You're going to aerobraid that, and you want to aerobraid just to this area here. You don't want to get anything airbraided beneath that. Then you're going to put clear opaquer on it, coat it with clear opaquer, and when you coat metal with pink opaquer, it looks more tooth colored. And so what if you forget the pink opaquer? We will take that out. Place our temporary post, and what you get is a gray area up around the gingival where the material, the gray shadow, right where the material is thin. And you can see how the material shows through because it's so translucent. And so I put it on with a Dical applicator and coat it nicely, and then you're going to cure it. Place it back into the mouth and clean off anything that's been leaking. And then you're going to put cotton in to protect your access. And you're going to fill your matrix up with impression material, or not impression material, but provisional material. And we used Pro Temp for this. You can use any one you prefer. Seed it into the mouth, and then you're going to wipe off the excess here with a little micro tip to get down to your cotton. Remove the cotton, and now you can get your driver in. So remove the matrix. Now you can get your driver in to remove the restoration. And that's me removing the restoration. If you get undercuts here or at the other side, then you have to just use a very fine pointed diamond burr just to clear the undercut. And that's it from all four sides. And now what we want to do is we want to fill in the gap to do our transition. And so I just used any flowable will work, and you want to fill to this little line right here. Continue to fill it all the way around. And now I'm on my second increment, and we're going to cure 40 seconds on each surface. And so that's from the buccal. That's the mesial. Now note the lingual, it might be very thin, and what we do is we add a convexity there for strength. Now that adds bulk. It's okay on the lingual because you have thick tissue and you won't get any recession there. Bulk. So there's less chance of recession. And that's the lingual shot and then the distal shot. So now you want to trim, and what you're going to do is you can use the free gingival margin as your guide. The CEJ should scallop around the tooth and should mirror the osseous and what the gingival scallop is. And using the free gingival margin as a guide, you're going to trim it flat for 1 millimeter apical to the free gingival margin. Interproximally, again, you're going to follow the scalp at the free gingival margin 1 millimeter apically before you start your transitioning to the shoulder of the abutment. When you start trimming down to the shoulder, you want a concave transition. And we use an acrylic burr to do that. You want a flatter profile on the mesial and the distal just to give some support to the papilla. And then polish, make it nice and smooth before you insert and disinfect in place. Now this is the one that was placed. Now this patient, again, came to me a little late. When they did the implant placement, it would have been nice if a CT graft had been placed in that area. I'm not sure why it wasn't in this case, but this is what we got, and there's not much you can do once the implant's in. And so that was it, day of insertion, and this is it now 4 months later. And you can see the gingival lines before we started, and we are actually about the same distance from that line with this restoration. So the vertical height of it is fine, it's just too far lingually. And the next way to do this is the anatomic harmony abutment. This is something that the surgeon can do quickly during the surgery before he places his bone graft. So what it is, it's a modification of the freehand technique where the extraction socket's used in vivo to guide the shape and contours of customized healing abutment. What you do is you take a temporary post, and you're going to micro etch that, and you're going to take some composite resin and just mold it into a cylindrical shape and wrap it around your abutment, and then you're going to place it into the mouth. You're going to screw it into place, and then you're going to use a plastic instrument to sort of work this material down such that it's level with the gingival margin before you light cure it. The abutment is then removed for final finishing and polishing. And that's, like I said before, that's intended for the surgeon to fabricate prior to placing a bone graft. And it helps to contain the bone graft so you don't need to suture your flap. And this is his diagrammatic representation of what it is. It's got support for the interproximal papilla, got a polished transitional zone. That's your transition zone on the implant. The gingival landing zone, so your gingival margin, your facial gingival margin will be right here, and he adds a little blue dot just to orient it for the restorative dentist. So the advantages of the anatomic harmony abutment is no flap is required to contain the graft with immediate placement. It approximates the emergence of the failing tooth and supports the gingival architecture. It can customize, the operator can customize the emergence profile, and you avoid the use of a stock healing abutments, which are non-anatomic. Limitations, the problem is, sockets collapse sooner after extraction, so it'll be a little bit under-contoured with respect to what you want it to be. And the tissue is flexible, so when you put it in, you might distort the tissue, so it's not going to be an exact replica of the emergence profile. And it doesn't reproduce the gingival embrasure form to support the papilla. So, summarizing the freehand technique, the advantages: no flaps required to contain the graft with immediate placement. It supports the gingival architecture. It helps to control bleeding. The operator has full control over the emergence profile and papilla support, which can be a good thing or a bad thing, depending on your level of experience. You can fabricate a provisional crown or custom healing abutment. And it's useful if there's no original tooth, delayed placement, or if the tooth is congenitally missing. Limitation: it's not an exact replica of the extracted tooth. The operator controls the emergence profile and papilla support. And so how does this relate to John Coyce's diagnostic keys? Well, as far as relative tooth position, well, this is sort of a maybe, that symbol. We're going to call that symbol right there a maybe. Relative tooth position is under the control of the operator, so it depends on your clinical experience with these things. Form of the periodontium, also a maybe. A freehand development of the gingival embrasure and the emergence profile. Biotype, you're not going to change it. Tooth shape, the matrix might preserve the the crown shape if it's available. Otherwise, you're doing a healing abutment. Or as I did in the one case, just fit a couple denture teeth onto the model, take an impression of that, which is not exactly the same as what it was before, but she never had teeth there before anyways. As far as the position of the osseous crest is concerned, it's preserved with flapless extraction, immediate implant placement, and bone grafting, but it might be influenced by the subgingival contours of the restoration if you over contour it. On to the next option, stock shells. Stephen Chu and their group published on this back in 2014. So stock shells are made of polymethyl methacrylate. They're customized in cross-sectional shape and emergence profile for incisors, canines, and first premolars. It's similar technique to the Harmony abutment, except the subgingival portion of the provisional restoration is determined by the shell. When you insert the shell, it helps to control bleeding while the temporary is being fabricated. And these can be purchased from Vulcan Custom Dental in Birmingham, Alabama, and they're about $29 a piece. So how do you do it? And that's what it looks like from the side and the top. And when you place it into the socket that your implant has been placed into, it fits nicely. And then what you're going to do is, sorry, the back one, it's in there. You see the implant down there, and then he places a PEEK abutment, the polyethyl ethyl ketone temporary abutment, and he's going to fill the gap here with polymethyl methacrylate to bond the two together. PMMA, there's the PMMA going in. And so then you're gonna fill up your matrix form, and then you're gonna create the coronal portion of your restoration and bond that to the PEEK abutment. And that's the provisional crown. So it's screw retained. And the nice thing about this is the shell controls all of your emergence profiles. The advantage is no flap is required to contain the graft with immediate placement. It supports gingival architecture. It helps control bleeding. And it simplifies the creation of some subgingival contours that duplicate the tooth. And you can fabricate a provisional crown or a custom healing abutment on top of it, doesn't matter which. Limitations: it is not an exact replica of the extracted tooth. It's available for not all the teeth, upper and lower molars, upper first premolars, canines, and incisors only. There's only one size available for each root form. So if it's a big root, then your restoration will be undersized. And polymethyl methacrylate is needed to customize the emergence profile, which is powder liquid. Not really a big deal. How does it do with 5 diagnostic keys? It's a maybe as far as relative tooth position is concerned, because the matrix might preserve it. Form of the periodontium, the shell approximates the gingival embrasure and the emergence profile. The biotype remains unchanged. Tooth shape, the shell approximates the subgingival contours. The matrix may preserve the crown shape if you have one. And position of the osseous crest. The osseous crest is preserved with flapless extraction, immediate implant placement, and bone grafting. Extracted tooth. Bob Margis was the first one to report on this, and Trimpu stated that a simulation of the exact dimensions of the lost tooth, especially on the cervical part of the new provisional restoration, is expected to preserve all relevant information and allow the design of the natural looking emergence profile. So why not insert the natural tooth? So these are the 4 studies that were published on this, and they were all done at about the same time. They all started about the same time. They just all had different follow-up periods. That's why they all have different dates of publication. So Margis published in 2006. Steigman did it in 2017. Trimpu had a longer follow-up at 2010, and we were 5-year follow-up in 2012 with Castle Nuovo. So Bob Margis's. So what he stated was that the use of the patient's natural tooth as provisional allows the tissue to heal in the exact cervical contour and emergence profile as the definitive prosthesis. Immediate implant placement of the extracted natural tooth and crown. Natural tooth crown following implant placement will maintain the volume and profile of the soft tissue contour. This was really, it was just a case report. He only had one patient and he only did about a 6-month follow-up. So you have to fabricate a putty matrix prior to tooth extraction. Once the implant is placed, you're going to hand tighten a temporary abutment. You're going to cut off the crown. This is the actual extracted tooth. You can cut the crown off 3 millimeters apical to the CEJ. You're going to hollow the inside of the crown out. You're going to etch it, bonding resin, and light cure it. And then you're going to reline that with bisacryl and place that in the mouth. And what you do is, this is the matrix up here. The matrix is going to help to preserve the exact position, buccal lingually rotation of the tooth before it was extracted. So this is in the exact same position as it was before it was removed. When you remove it, you still have to fill in the gap between your provisional and the top of the abutment. And you can do that again once with flowable. And once it's done, you're going to put temporary luting resin into the crown, and you're going to take an analog with another abutment on it, and you're going to place that on there. And then what you're going to do is you're going to remove all this excess. And the reason he does this is so you don't get cement forming, so you don't get cement being extruded down near the head of the implant. So then you're going to place it in with very, very minimal cement. And that's his result at 2 months. And if we draw our lines on it for the gingival margins, you can see he's done very well as far as resection is concerned. It's about exactly the same. Papilla form is retained and may even be better than what he had originally. And as Michael Fling said the other day, the best way to have a good papilla is to make sure you have a little bit of a saliva with bubbles in it when you take your pictures. So the other studies, there's 3 other studies. And so we're going to look at Stagman's study next. And so it's a very similar technique to Margis using the natural tooth. They had 10 patients and they did a 2-year follow-up. What they found was that the papilla appearance remained the same in all subjects. Soft tissue thickness, they lost about 0.6 millimeters was noted at 6 months, but that was reduced to 0.3 millimeters at 2 years. Probing depths decreased by 1 millimeter at 6 months and then remained stable. Radiographic bone levels remained stable for over 2 years. There was a minor increase in attachment at around the implants at 1 year, and immediate implant placement with bone grafting results in less crestal bone loss. Next one, Trimpu, in 2010, what their rationale was is the healing process associated with a replanted tooth is based on the optimum sealing of the defect. Reimplanting a natural tooth on an immediate implant simulates a near naturally dimensioned sealing of the dentogingival soft tissue and initiates healing repair process similar to that of root replantation. It converts the healing process from that of an extraction socket to one of replantation. The peri-implant soft tissue interfaces with identical shape and dimensions of the lost tooth, but are also identical surface structure and biocompatibility. Now, this was a case study and there was no follow-up and there were no measured parameters. And the last one was Castelnuovo. So it's a similar technique again to Margis using the natural tooth. The presence of the natural tooth structure, which is cementum, CEJ, and enamel under the marginal soft tissues. Sorry, go back. All right, here we go. It requires an intact tooth, which is free of restorations and endodontic therapy. Complications are tooth fracture, discoloration, decay. There was one case that was presented with a 5-year follow-up, although they did 4 cases. They only presented one of the 5 cases. So we're not sure if all of them are successful. They weren't presented, and they didn't measure any parameters. This is the case that survived to 5 years. So we're looking at the upper left central incisor. And we're going to look at the gingival margins here. So at 5 years, it was about the same. Gingival margin. This is the contact point. It was exactly the same. We have a little bit of a black triangle here at 5 years, although on this side it was filled with saliva, and they look to be about the same. And now we're looking at the distal papilla right there, and we had a little bit of loss of distal papilla. But this is an extracted tooth on a temporary abutment, and it lasted for 5 years. So the advantages of using the natural tooth is no flap requirement to contain the graft with immediate placement, supports the gingival architecture. It's an exact replacement of the gingival supporting tissues. And this is probably the most important one. You have a biologic surface for epithelial and connective tissue reattachment. Limitations, it's cementable. You can modify it to be screw retained, but you lose structural integrity. It requires a structurally intact tooth above the implant platform. And you can't modify it for a reason that if you cause repeated connections and disconnections, you wind up with recession. And we're going to talk about that in a few slides. So how does it do with the 5 diagnostic keys? It does very well. Relative tooth position, the matrix preserves the relative tooth position. Form of the periodontium, the natural tooth preserves the gingival embrasure. Biotype of the periodontium, doesn't change. Tooth shape, well, it's the exact same tooth. And positioning the osseous crest, it's preserved with flapless extraction and immediate implant placement with bone grafting. But you can't use it if this is your situation, or this situation with a vertical root fracture. Which brings us around to making a replica of the extracted tooth. How am I doing for time here? Good. So Eric Van Duren is the first one who sort of informed me about this idea, but he's never published it. And so we worked out the method to do it, and we're going to show you that. And we're going to also show you how you can take it and modify it to do a little bit of tissue sculpting if you really want control. All right, so natural tooth replica, unpublished data. The article is almost finished. So this is brand new stuff. The position and form of the free gingival margin and papilla are determined by the shape and the volume of the supraosseous portion of the restoration. The subgingival contours and shape of the cervical root area of the failed tooth should be replicated in their post-extraction state. That was quoted from Stephen Chu, 2014. The natural tooth abutments provide optimal support for the tissues. Creating provisional restoration has the replica of the natural tooth should also provide optimal support of the gingival tissues. So this is Sam. Sam is a 47-year-old male, healthy airline pilot. Gingival margins of the central incisors were on a line connecting the gingival margins of the canines. The mesial papilla had small black triangles. Distal papilla had about 50% fill. It was M1 mobility, and number 11 or number 8 in the US had 6 millimeters localized lingual pocket with bleeding on probing. Diagnosis made of vertical root fracture, and we decided to remove the tooth. As far as his diagnostic keys, before we started, relative tooth position, he was ideal in all 3 dimensions. Form of the periodontium, he was high scallop biotype, he was thin, tooth shape, moderately tapered. Those were artificial PJCs, and he was low crest, unstable. As far as the radiograph is concerned, there was a poor crown to root ratio, the margin being right there. The osseous crest is more than 2 millimeters from the CEJ. There's good osseous scallop at the mesial. It was a very flat scallop at the distal. So this is where we're having trouble with the distal papilla, and diagnosis of cracked root on the lingual. So we know that recession is going to be a concern. Reconstructing the distal papilla will be a challenge. We would ideally prefer to orthodontically force erupt this. However, we risk bone loss due to infection. And we're not going to get any improvement of the situation over here because the papilla is determined by, in part, the attachment to the adjacent tooth. So how do we do it? First thing you need is a really good impression of the pre-extraction state. We are going to remove the tooth and have a look at the socket, drill our pilot hole. That's our guide pin. There's our implant there, and healing abutment. And this is how he shows up on my doorstep. Oh, sorry, no, they put the bone graft in first. And we took a transfer impression with an impression post. And there's our putty matrix for the impression post. There was the tooth extracted. This tooth has a long history. You see some root end surgery had been done on it. We'd done forced eruption on it previously. And then see where the part of the crack is down the root right there. Now this is the meat of it. So what you want to do is you want to take that tooth, you want to put it back into your impression. And you're going to put some Gingival. This is the same stuff the labs do. You can take that and you're going to trim it over here and trim it over here. And then we are going to pour. This is our first pour. You want to leave the tip of the root sticking out. And what you're going to get, so what you do is you have to remove the tray when you do this. See, the tray is off it because what you need to do now is, this is very fragile. You need to peel your impression away from the model. So now you're set up with the tooth embedded in the exact same position as it was in the mouth, and that's represented in your model. And there's your occlusal view. And now you're going to remove the tooth from the model, and you're left with a negative impression. Now what we're going to do is we're going to take our transfer impression post and add an analog to it. And we're going to place that on top of our model. And this little gap here, we are going to fill with wax so that when we do our second pour, we don't get any stone down around our temporary abutment. And so this is it now poured with our matrix removed and the impression post in place. We're going to remove our impression post, and you can see the implant analog down there. We're going to do it just like we do with our freehand transition. So we're going to sandblast our post and cover our access with cotton, protect their screw. Now we're going to inject right down to the top of the temporary post. Fill up our matrix and put that on top. Clear the soft material away before it hardens, get down to the cotton. We're going to remove the matrix, and you can see the cotton is still in place here. You're going to remove it. And now you can see that you've got a root structure. This is the negative of this replica of the root right down to the top of your temporary abutment. On the lingual, because the implant was placed lingually, we were really close to the gingival, the socket margin. And that's the lingual, and that is the distal. And now we're going to just compare that to, this is what you get on the right when you just do a freehand. You get a lot more information down to the margin of your temporary post. From the mesial, from the lingual, and from the distal. And that's our final polished restoration, ready for insertion from all sides. And we put it in. This is day of. This takes about 90 minutes to make. Our gingival margins seem to be in a good spot right now. And 5 months post-op, we've had some recession. So I got one shot at this to fix this, because we know that frequent disconnections increase the likelihood that you're going to get recession, especially in a thin biotype. So what we're going to do is we're going to remove it. We're going to trim this to hollow it out and hope that the tissues come down. 4 weeks later, we got a little bit back, and there's our distal papilla. So what we're going to do here is we're going to move the contact point from here apically by adding material onto this, and I think we added some onto here as well. Now these are the final crowns on insertion. The mesial contact is more apical. The distal contact is longer. And what we did is we attempted to gently squeeze that papilla to get it to fill the black triangle. There's a radiograph, and you can see here where we added some material onto that tooth. And this is the final crown. And so we didn't get much back as far as our recession is concerned, but our black triangle at the mesial is filled in, and that was the smile. So he had a low lip line. It didn't really seem to bother him. He was happy. So now this is a 3-year follow-up now. What we found was we had, sorry, this is on insertion, and that's our 3-year follow-up. And what we've had is we had a little bit of recession happen on this root here as well, and we lost a little bit there as well, but our papilla is fine there. This is before, and that's how we're able to get our papilla on the distal. And that is his smile, and he's happy. People worry more about the papilla over the tooth length, especially with a low lip line. So how do we do with this? Natural tooth position, matrix preserve the relative tooth position, form of the periodontium. Natural tooth replica preserves the gingival embrasure, biotype remains unchanged, tooth shape. The original tooth shape is preserved, and position of the osseous crest was preserved with flapless extraction, median implant placement, bone grafting, but the natural tooth may provide more robust gingival attachment. Okay, so I mentioned before that frequent abutment disconnections and reconnections cause recession. Well, who looked at that? Abuiment did studies back in 1997 with dogs and Brandemark implants. What they did was they had 5 dogs in the mandibular premolar area, 1 implant per quadrant. The contralateral implant surge is the control. They removed the tooth. They waited 3 months for delayed implant placement. Then they waited another 3 months for uncovering and abutment connection. And then what they did was 5 times after putting the temporary on, once a month for the next 6 months, they would remove it, disinfect it, clean it, and then replace it. And then they measured. And then what they did was they processed the specimens for histologic examination, but they only did that 1 month after the final disconnection. Now, this is a diagram of the implant with their temporary abutment on it. This is the gingival margin. That is the apical extent of the junctional epithelium. So this is sulcus plus epithelial attachment. This is the connective tissue attachment here. This is in the control, and on this side, the test. And so when we looked at the data, they found their junctional epithelium was 2.04 millimeters, and on the test subjects, it was down to 1.65 millimeters. The connective tissue attachment down here was 1.28, so you get and on the other side, you get 0.85. So on the control, you get about 3. Now that's your 3 millimeters of total gingival complex, which is what we come to expect. And over here, it was reduced to 2.5. Now, however, they did this only 1 month after the final disconnection. So tissues often take longer than that to mature. And what they did was they found that this was not statistically significant. And the problem with that is, well, they only have 5 dogs. You can't plot a bell curve with 5 data points. So they had a small sample size. And so what do you do when you get a result that's not statistically significant? You just do the small sample size. What do? You change your measurement criteria. So what they did was they changed it. Instead of measuring these, they went from the microgap. They measured from the microgap. And when you measure mucosal margin down to the microgap and then microgap down to bone, then you found that this measurement was 2.54 millimeters versus 1.02 millimeters on the test group. The microgap to bone measurement was 0.78 compared to a microgap to bone in test group of 1.49. And what they found was 1.5 millimeters recession, and they were able to get statistically significant differences there. Now, this is their conclusions here. The transmucosal barrier consists of connective tissue component and an epithelial component, of which the connective tissue is about 1 to 1.5 millimeters, the epithelial component is 2 millimeters. That's biologic width. This barrier protects the zone of osseointegration from factors released from plaque in the oral cavity. Disconnection and reconnection of the abutment compromises the mucosal barrier, and the connective tissue attachment will then reestablish itself at a more apical position. The mechanical disruption of the mucosal barrier may be considered as a wound of the connective tissue, resulting in epithelial proliferation and resulting in bone resorption to allow the biologic width to reestablish at a proper dimension. Now, this was an animal study. It's not certain whether that's fully relevant to humans. And so what about if you only do 1 or 2 reconnections? As we would do is if we were taking our temporary off to take an impression for our final prosthesis and then remove our temporary again to insert the final prosthesis. They looked at this as well. So they took 6 dogs with delayed implant placement. Okay, so they waited 3 months before they placed it. And they put 3 implants at each site. The second stage surgery was 3 months later, delayed, with 3 different types of healing abutments. There was 2 temporary abutments and 1 final abutment, which was used as a control. And they were placed with full flap. 6 months later, they did histological examination, and they found that the largest radiographic bone change occurred before the implants were exposed to the oral environment. Single disconnection from the healing abutment to final prosthesis did not cause any additional bone loss. So you can do 1 or 2, but if you do a whole bunch of them within the first 5 or 6 months, you will get recession. What about people? Saito, with Chu and Tarno's group, they did a retrospective study of 18 patients. And what they did was they looked at the gap between the implant and the buccal bone. Sorry, the gap between the implant and the buccal bone was grafted with either inorganic bone, bovine bone, or cancellous bone, mineralized allograft. The graft was extended all the way to the gingival margin, which is their dual zone grafting technique. They did immediate provisionalization with iShell, and they did their first disconnection. Now this is 5 to 7 months, not 1 month. And what they did was they looked at whether there was bleeding or not. And they looked at what the buccal lingual ridge dimension was, and they measured that off of stone models that were used to fabricate the final restoration. And they took measurements, right at the gingival margin, 1 millimeter apical to 2, 3, 5, 7, 9. All the way down. And what they found was, they used the contralateral tooth measurements as a control. What they found was in 11 of 18 cases, there was bleeding upon disconnection. So 61% had bleeding, the rest had no bleeding. And the bleeding was associated with a significantly wider buccolingual ridge dimension than there was with no bleeding. So see how thin this is here and how thick it is here. In the range of 0 to 3 millimeters from the gingival margin. And what they concluded that the presence of bleeding upon disconnection of the provisional restoration was associated with stability of the buccolingual ridge dimension. So bleeding is really equal to attachment of the tissues to the abutment, and which is a better barrier to protect the implant bone interface. So you tend to get less recession, less bone loss. They postulate that the long junctional epithelium adheres to the gingival surface of the provisional restoration. Removal of the provisional restoration disrupts this adhesion, resulting in bleeding. Bone grafting to the level of the gingival margin may promote supra-implant adhesion to the provisional restoration. but they had no control without dual zone grafting to support that statement. They provided no speculation as to the reason why some sites did not bleed and how to ensure successful adhesion. They provided no explanation regarding the possible effects of the two different bone grafting techniques that were used. And there was no histologic analysis, but you can't do that in people. So what do? They did another study. Again, this was really a case report where they examined the provisional restoration following the first disconnection after 5 months with scanning electron microscope. And then they did immunogold cell labeling. And what they found was they noted circular bleeding was noted when they disconnected. The SEM revealed that there was well-spread fibroblast-like cells with filopodial extensions inserting into the porous surface of the provisional restoration. That's what you want. You want things to seal. Keep the bacteria and the biofilm out. Immunogold labeling suggested that these cells were fibroblasts. And where they were not adhered, they had biofilm. And so, the conclusions, although this is it's a case report. You can draw conclusions from a study, but not really a case report or a pilot study. This really just a proof that the technique will sometimes work. So what you need to draw conclusions is a well-designed randomized clinical trial that's double-blinded and prospective. So they suggest that bleeding results from ulceration of the succular lining and or disruption of the adherent mucosa at the abutment interface. Adhesion of the mucosa to the abutment surface may impede epithelial downgrowth and create a more effective biologic barrier. This adhesion may also serve to support the peri-implant mucosal tissues. Which brings me to Dorothy. Dorothy is my wife, and so 50-year-old healthy female, tooth number 26, or number 14 in the US. She had some sinus pain, and then her left cheek became very swollen, left side of her face became very swollen. On the PA, maybe I can see a little bit of something here, not an awful lot. You go to the CBCT, and you can see that sinus membrane is remarkably swollen, and you've got bone loss in between the roots. And on the other view, you can see that it's perforated the sinus. And so, okay, yeah. And so we remove the tooth and we let that heal for 6 months. Section the tooth into 3 pieces, pull each root out individually, let it heal. And what you see here is a little Maryland bridge we made her as a temporary. 6 months healing, you can see that the membrane first off is remarkably back to normal. And this is filled in with bone, so she's ready to have her implant placed. This is the tooth that has been removed. And so now we're going to use this technique in the posterior, but then you have to somehow reassemble this tooth in order to do this technique. So what I did was I used some orthodontic wax that you give to the kids so that their brackets don't traumatize their cheek. And I just put the 3 pieces back together again. And we are going to then put that into a pre-op impression. So what I used here was a material called Alginate in a regular tray. And we're going to put our Gingival in there. We're going to trim it and pour it. And this is an example of what you do not want to do, because I could not get the tray separated from the Gingival. This material is too stiff. And what happened when I did that is this split right across here. That's very thin there and very thin there. So what you want to do is you want to use a flexible material. So I just took a little quadrant tray and took an impression with it. And that's the tooth right there. And you can see there's no tray on that. We are going to lubricate it. And this is glycerin gel, which does not work as well as Vaseline. Vaseline works the best. So lubricate the impression because you want your impression to come out very easily. Place the tooth in, place your Gingival, and then you're going to pour the model. You want to make sure that you keep this area clear, the furcation of your impression material. So you're only going to fill up to the furcation area. That's your model with the tooth in it. How do we get the tooth out? What we're going to do is we're going to melt that wax by placing this model into hot water. The wax will totally dissolve, and then you just pull the 3 roots out individually. Now you're going to take your transfer impression, put your post in there, attach an analog to it, and place it on the model. Once again, we're going to put wax here so I don't get dental stone down to my impression. There's the wax. Going to do our second pour. Now we're going to remove the matrix impression and the impression post. And that's what we get from the top. There's our implant head and our sandblasted temporary post in place. And what you want to do is you want your wax to come up to this level right here. So right there, you want your wax to come up to that level. And so all this wax here can just be sort of sculpted away, and until that's got to be cleared there. And then you're going to inject your temporary material and fill it up. So we're making just a customized sealing abutment. We don't want any occlusion on this. And if I had my way, I think I would have trimmed this little excess off the model right there, make that tooth a little bit more on top. We're not making a contact point, so it doesn't matter. It just helps with visibility, because you can't see how much of that Gingitech material is underneath that there. And so when you remove it, this is what it looks like. And there's your occlusal view. And now we want to start trimming it back to the shoulder of our abutment. And you can see there is the margin of the abutment. I got a little bit of material beyond it because I didn't have wax there. And there we go. And now it is decision time. So how do I shape my emergence profile from the gingival margin down to the margin on the shoulder on my temporary abutment? I've got 3 choices: concave, straight, or convex. Concave is represented. Some manufacturers produce concave stock abutments. Some produce straight stock abutments. Nobody produces a convex straight abutment, a convex abutment. And so to understand what we need, which one we want to do, we need to understand the biology of the attachment to the abutment and how it differs from the attachment to tooth structure. So this group did a histologic analysis of Japanese snow monkeys, where they looked at the factors that determine the blood flow to the gingival soft tissues and the effect on the bone. What they found was blood supply to the connective tissue around the teeth comes from, so the blood supply to the connective tissue here around the teeth comes from 3 areas: from the periodontal ligament right here, from the alveolar bone via the periodontal ligament, and from the alveolar bone directly to the connective tissue. After extraction and you place an implant, we lose the periodontal ligament. So what happens? The blood supply to the gingival connective tissue is reduced due to the absence of the periodontal ligament. So bone resorbs apically, usually to the first thread in a conventional implant, and the ridge thins buccolingually. There's also a reduction in the cancellous bone and an increase in the cortical bone. So there's less vascularity, which means it's harder to do bone grafting afterwards. Alveolar bone supply migrates apically, where there's more cancellous bone. And so this may predispose us to a loss of soft tissue volume. Now, around platform switched implants, it helps to move the microgap away from the bone, which helps to preserve crestal alveolar bone. The greater bone volume can also increase the blood supply to the gingival soft tissues. So in summary, peri-implant tissues have reduced blood supply compared to that of natural healthy teeth. Platform switching aids in preserving alveolar bone volume and therefore blood supply to the gingival soft tissues. This may reduce the amount of recession that can occur following implant placement. So with our emergence profile, Schoenbaum wrote an article, a technique article on emergence profile. And he says that it plays a significant role in the creation and maintenance of the gingival architecture. And manipulation of the emergence profile cannot guarantee success. So, sufficient tissue volumes are also required. And soft tissue around implants differ markedly from that of around natural teeth. It's less vascular, it's much more fragile, and it can create greater volume. So what they found was in natural teeth, the connective tissue attachment, the transverse fibers insert at right angles into the root surface. These are the Sharpie's fibers, I believe. Whereas around an implant, the transverse fibers reorient into a circumferential around the implant and parallel to the implant. Upon maturation, these fibers going circumferential, they squeeze down and they form like an O-ring at the point of minimum diameter, which helps to provide the seal around an implant. Traditional implants, it happens at the first thread, whereas platform switched implants, this attachment is much more coronal and it contributes to the preservation of peri-implant bone and soft tissue. It takes 4 to 6 weeks for maturation, and it's a much more fragile connection. So the convex emergence profile, the larger diameter compresses the soft tissue, which you would see as blanching. It displaces the gingival soft tissues more apically. A concave emergence profile allows for an increase in soft tissue volume and allows the soft tissue to drape more coronally. Now, these are the two statements that sort of form the basis for his entire argument. You know, if you emergence profile of the implant abutment and its effects on the peri-implant soft tissues, that's really what this article is all about. And here's the statement. What he says is a larger diameter emergence profile will compress the soft tissue and move it apically. That was the first one I showed you. While a narrowed emergence profile will allow the soft tissue to drape to a more coronal position, figure 6. But what's missing here? What's supposed to go right there? There was no reference. So this is really, it's an unsubstantiated statement. And has anybody proven this? So I'm not really any further along in my decision making. So let's see what else he has to say. So there's no way to determine the magnitude of either of these effects. It must be tested in situ. Tissues must be given enough time to respond and mature before making adjustments. So you need 4 weeks for maturation to occur, 4 to 6 weeks. A repeated disconnection of the components results in significant loss of peri-implant bone and soft tissues. Those were the Abuiment studies in dogs that we just reviewed. So you want to minimize adjustments to the emergence profile, and you want to postpone at least 4 months following implant placement. How do you manage the papilla? The mesodistal width of the tooth in the cervical area should mirror that of the contralateral tooth, or be identical to that in the case of the extracted tooth or our replica. Compressing the papilla from the side to increase its height is unpredictable. You want to design the provisional with open gingival embrasures to allow the papilla to mature to its maximum vertical height. And you want to close the remaining space of the final prosthesis by moving the contact apically. Again, we had no references to back up these statements. So in summary, the temporary abutment provisional restoration should be biocompatible, titanium, zirconium also. High strength, should be platform switched. It should have a narrow or concave emergence profile to maintain blood supply and promote a thicker band of soft tissue. Should be left undisturbed for 4 months, and then you can make modifications to the emergence profile. But you have to allow for between 4 and 6 weeks between modifications to allow for tissues to mature and adjust, and you can't do it too often. So how do you go about sculpting the tissues? So Sue and Wisegold in Philadelphia, this is a very heavily cited article about how to tissue sculpt, and we're going to look at it. So this is a pilot study, but more accurately, it's a technique or an observational article. They had 2 cases. There's no control group. There was no measurements. There's no statistics. The concept of gingival reactions to over and under contouring restorations is based upon observations of 2 supported restorations. So they're just trying to apply that to implants. They observed that the gingival response to changes in the emergence profile of an implant supported crown depends on the location of the contour change. And they define 2 areas of significance, and they call them critical and subcritical contour. What is it? All right, so the red line on this diagram represents the gingival margin. The blue area represents the critical contour. And the critical contour is defined as the area of the restoration located immediately apical to the gingival margin, about 1 millimeter in vertical dimension. Although that's a preliminary observation, they only had 2 subjects here. They didn't have time to test different variations in vertical dimension. It does follow the circumference of the tooth along the CEJ, and it determines the position and the shape of the buccal gingival margin. Subcritical contour is the area of the restoration in orange that is located apical to the critical contour. It follows the circumference of the tooth, but it requires enough running room. Running room is the distance between the critical contour up here and your implant head. So it's the distance from the implant neck to the gingival margin that provides proper cervical contour for the restoration. It may not exist if the implant is placed too shallow, so you won't have enough running room. But it should not affect the position and shape of the buccal gingival margin, provided that you make adjustments within the physiologic range, which they never defined. So subcritical contour can be convex, concave, or straight. Critical contour manipulations. You can move the critical contour buccally, which will result in facial gingival margin moving apically. You can move it lingually, hollow it out, which results in the facial gingival margin moving coronally. And you can move the buccal height of contour mesial or distally, and what that'll do is it'll affect the gingival zenith. It'll move it in the direction of the change in the height of contour. So if you hollow it out at the mesial, the height of the gingival contour will move away from that. Critical contour manipulations. If you bulk the critical contour interproximally, the crown form becomes square. If you thin the critical contour interproximally, the crown form becomes tapered. So effects on the buccal gingival margin, the critical contour. Just going to review these now. If you move the critical contour buccally such that it becomes convex, the buccal gingival margin moves apically. If you hollow it out such that it becomes concave, the gingival margin moves coronally. Subcritical contour, if you hollow it out such that it becomes convex or concave, it reduces the risk of recession because your tissue becomes thicker. It's useful to gain maximum tissue volume during healing. And if you move it buccally, make it convex. The facial gingival margin moves buccally, but it also moves coronally a little bit because you've got all this extra tissue here. It's going to move out. It's also going to drape down a little bit. You may get a little bit of coronal movement. They state that small adjustments are essential. You don't want to compromise blood supply, but they never define the size of the adjustments. Now, if recession ever does occur and you've done this, then your subcritical contour will then become your critical contour, and it'll be over contoured, and you will get recession. So you want to be very, very careful. What are the effects on the papilla? Subcritical contour. Ideal critical contour and concave subcritical contour is suggested to maximize tissue volume during healing. So for your papilla, you want it to be concave during healing, and then you will adjust that later on. Now, this wasn't anything that they did. This was based on a study by Rompin in 2007. And this is the study. And so again, this is a pilot study, a pilot clinical study. They had no control group. They used bone level replace select implants, non-platform switched abutments, and they had a concave emergence profile. They used implants made out of titanium and zirconia. And this is what their model looked like. So concave, 3 millimeters of a concavity. They had 40 patients with 54 implants in the anterior and the premolar teeth, upper and lower. Inclusion and smoking were uncontrolled variables, biotype, etc. Those things weren't even mentioned. There was 2 practitioners. Some were immediate placement, some were delayed, some were 1 stage, some were 2 stage. Temporary crowns replaced either at implant placement or at uncovering. Measurements of recession were made from photographs taken at either 12, 18, or 20 months. They also had a subjective assessment of the aesthetic outcomes, and those were made by either the treating clinician or they had an independent observer. So if it's me doing it, yeah, I might be a little biased as the result of my my experiment. So it introduces bias into the study. And so this technique is also, it's really difficult to do on platform switched implants just because the connection is already narrower and you would be making it further narrower. So that's why they use this type of implant. So what they found was there was no recession greater than 0.5 millimeters at any time point. Some had a transient gain in soft tissue, vertical dimension that disappeared with the final restoration. All aesthetic outcomes were rated either good, very good, or excellent. Their conclusions, although it's a pilot study, you can't really draw conclusions, you can make suggestions, and that should be tested in a proper study. Less than 0.5 millimeters recession was found with concave abutments. This was stable up to 24 months. They suggest that stability is due to increased volume of the tissue and a longer vertical soft tissue interface, which improves biologic seal. So if you go back to the diagram where it was really concave, if you straighten out that concave feature, you've got a longer surface. After maturation and wound contraction, you get a ring-like seal forming around the narrow part of the abutment. And they haven't published a follow-up random clinical trial, and that was done almost 13 years ago. So effects on the papilla, subcritical contour. Back to Sue and Gonzalez and Weisgold's paper. So after gingival healing, subcritical contour can be modified to be convex. One clinical case was presented, but they only had minor changes. It requires at least 2 to 3 millimeter wide papilla to even think about it. And you have to let tissue maturation and gingival margin stabilize prior to any adjustments, which takes about 3 months according to Small and Tarnow. The volume of the additions and the relative convexity are undetermined. They didn't say how much to add, or and the long-term stability of these changes is also undetermined. So based on the evidence this was based on evidence by other authors that applying pressure to the papilla can increase the gingival height. So the soft tissue aesthetics around implant restorations can be modified through contour modifications of the abutment. These effects vary depending on whether the alterations are made to the critical or the subcritical contours. These are based mostly on conclusions drawn by other authors. Little evidence was presented. All right, and so Vince Kokich wrote an article back in 1996 where he looked at black triangles and how you can close those orthodontically. So this article was similar to a review article, but he had very few references. It explains 3 causes of the absence of papilla and solution, and they are divergent roots, and the solution was to upright and parallel the roots, triangle shaped teeth with incisal contact points, and loss of crestal bone. So with the last 2, the solution is to shave the contact area and orthodontically pull the teeth closer together to close the space. Now that was done with moving natural tooth and crowns of teeth. It wasn't done with implants, so it's different biology and you can't move an implant. And he provides no references to back up the statements, but it just works. I've done it, and we showed that in the first case that I did. So where does that leave me? So what do we know? Okay, very little, if any, evidence for me to make an informed decision. So concave emergence profiles seems to encourage thicker tissues. A thicker tissue seems to be more resistant to recession. And we may be able to encourage papilla to fill the embrasure, at least partially, with additions to the critical and subcritical contours. That's not really been proven yet. So we're going to do a clinical trial. We have an N = 1. There's going to be no control group. The subject's going to be randomly assigned to the experimental group. It's not blinded. There were no measurements. I didn't do any statistics, nor did I do any histology. So this is really what a case study or a pilot study is. A pilot study is really just to prove that you can do something, and if it can be done, then you can test it. So I'm going to make a concave subcritical contour here with a round diamond burr. And that's the final contour that I came up with. We're going to cut off the top of the temporary abutment, and we're going to polish it and get ready for insertion and disinfect it. And that's it on the model. So all that trimming, I managed to maintain the shape of the pre-existing tooth. There's the polish. There's the healing cap that's in. And there is my temporary customized healing abutment. And so if we look at this now, after 5 months, this is how much we lost vertical height here because of bone resorption. So she had some exostoses here, and that just disappeared with the 5 months of healing. See that? Now over here, yeah, we got some recession, but if you look at the gingival margins, they seem to be pretty coincident. Also the papilla here, remember this surface on my temporary was kind of concave. And so I don't have an awful lot of support for my papilla there. So we want to see if we can't do something to grow some papilla. I had a better papilla on the distal. I did that, and then that. And there's my lack of papilla. So what we're going to do is I've got a very concave emergence profile here. We're going to bulk that out. And so here comes my addition right there. And so subcritical contour, we bulked right out, and this we just sort of flattened off. And so it's the difference between the two. When I put it in the mouth, this is the before, And you can see how the distance here has shrunk. That dimension there is much wider than what it was before. That's the before. And that is the after. And now with the intraoral camera, this is just after insertion of my my revised customized healing abutment. You can see that the tissue is blanching here. We also here is maybe add some bleeding over here, but we've got biofilm in this part here. See how thick the tissue is at the mesial papilla, and what we've done is we've squeezed it here to blanch to see if we can't grow some papilla. 1 month later, we removed it, and I'm starting to get some papilla forming here. Got a little bit of a caul developed there, and the final restoration in place. Now, this was day of insertion. We still have some black triangles here, and we're going to see if that improves. And we just had our 3-month follow-up, and it's starting to form here, although those can take much longer to fully fill in. Between 2 natural teeth, she's also got a little bit of a black triangle, so I'm not sure if I'm going to be able to achieve much more than that we've got there already. So how does it do with the 5 diagnostic keys? Insofar as relative tooth position is concerned, the matrix preserves relative tooth position, although there is no coronal portion to that. Form of the periodontium, that's a maybe. Preserves the buccal margin, but may not be fully supporting the papilla. The biotype remains unchanged. Tooth shape, there is no tooth shape because there is customized healing abutment, and its position, the osseous crest, is preserved with flapless extraction and immediate implant placement. Finally, customized impression post. So if you do all this work and then you just put an impression post in and inject your impression material around and take an impression, you send that off to the lab. What the lab's going to do is they're going to take the model, and they know that the tissue shrinks. So they're going to take the model, they're going to relieve it, but they're just doing their best guess. And so what you'll notice is when you insert that, you'll get tissue blanching on insertion. So whenever I do something like this, we always do a custom impression coping. If you provide them with that, they will provide your emergence profile to exactly what you give them. So why fabricate a custom impression coping? You want to preserve the emergence profile developed with the provisional restoration. The gingival tissues collapse when the provisional restoration or custom healing abutment is removed. So how do we know this? What's the evidence? How long does it take? How much does it collapse? Well, Chu, in their article, they made the statement that during impression making, mucosal tissues tend to spontaneously collapse after removal of the provisional restoration or custom healing abutment. What's missing? A reference. So I found another paper, and they state that the 3-dimensional peri-implant architecture cannot be captured with elastomeric impression material, as the soft tissue quickly collapses and adapts to the impression post circular circumference. And he provided us with 2 references. So let's look at those 2 references. The first one, Coelho. They state that in the provisional crown is removed from the mouth during the impression procedure, the gingival tissues tend to collapse and the impression material cannot produce a master cast with an accurate reproduction of the gingival contour. What's missing? A reference. Okay, let's look at the other article by Shore. And he states, upon placement of the impression coping in the mouth, soft tissue quickly adapts to its contours. What's it missing? A reference. So this is how unsubstantiated statements become dogma. So here's someone who referenced 2 articles, who made the statement, referenced 2 articles, but neither of the articles had could point to anybody who's actually proved this. So we want to preserve the emergence profile developed in the provisional restoration, and the gingival and we have an idea that the gingival tissues collapse when the provisional restoration custom healing abutment is removed. So Hines is the guy who sort of first described how to make a customized impression coping, and we're going to show you that technique right now. We're going to look at the upper left lateral incisor. We are going to remove the temporary crown or provisional restoration. We're going to place it on an analog. We're going to take the cup. We're going to fill it with I got these in the wrong order. We're going to take a cup. We're going to fill it with, nope, there. And then we're going to take a cup. We're going to fill it up with a fast-setting vinyl polysiloxane material. I use Jet Bite in this case. And then we're going to take that with the analog on it, and we're going to stick it right down into it. Then we're going to remove the crown, and you can see that the analog is buried there. Now, it's very important that you remember which side is buccal. That was my buccal side. And so then you're going to take your transfer post, your impression post, and you're going to sandblast it. You're going to put it in there, making sure you remember which side is the buccal side. And then we're going to inject flowable into the gap, and we're going to cure it. And then we're going to remove it. This takes just a couple minutes. Does not take very long. And that is your customized impression post, which you are then going to see how it sits in there, and then you're going to put it in the mouth. And this is why you mark the buccal, because I've got that rotated 90 degrees, and I didn't take a picture of it in there properly. And that's the result you get. So here's our final restoration. 1 month follow-up. And gingival margins were quite good. This patient came to me from another dentist who, and she just had a flipper in there. And so we made a customized provisional just with the freehand technique. And this is the final. Okay, so that was her final restoration. So in summary, what do we know? 1 to 2 millimeters of buccal marginal recession can be expected following tooth removal and implant placement. Coise's 5 diagnostic keys should be considered and, if possible, controlled when treatment planning prior to tooth removal. Surgical placement of the implant should favor the preservation of the marginal bone. Papilla preservation can be facilitated with an immediate implant, an immediate provisional restoration that mimics the failed tooth. Abutment disconnection and reconnection should be kept to a minimum. We know little about the quality of the gingival and soft tissue attachment of the materials used for provisional and final prostheses. We know titanium is good. We know zirconium is good. The PMA abutment that the eye shell is made out of seems to work most of the time. The materials we used here, I couldn't really find very much good information on them. Concave transition or Emax, either the final crowns were made out of Emax, and there's very little information on soft tissue, connective tissue, and epithelium adhering to Emax either. A concave transition from the round implant abutment connection to the emergence profile seems to promote a thicker gingival complex. Altering the critical and subcritical contours can assist with tissue sculpting to alter gingival levels and papilla height, but this still remains unproven. They really need to do more thorough studies on that. The magnitude of the effects is unknown. A customized impression post can be used to counteract the effects of the purported gingival collapse, which no doubt does happen. It's just no one's quantified how fast it takes or how much of an effect there actually is that can occur during impression taking procedures. And with that, I would like to thank you for your attention. And so this is a photograph of Toronto that I showed at the beginning of the slide. This was taken quite some time ago, and say thank you. And this is how our city has built up over the last 15 years.
Well, thank you, Dr. Douglas. That was really a nice summary of where we're at with aesthetics, and well done with all the literature. So, and you finished with time for questions. So people, take a look at your Q&A section. And if there's a question you like there, upvote it so we can get to the questions people are most interested in. I'm going to start off with the first question. Do you risk patient not returning for final crown because it looks too good, the natural tooth?
Yeah, I make it very clear that this is a temporary thing and they are not to function on it. And what people ultimately want to do is function on it. I had one patient I was a little worried about. Again, it was a friend of my periodontist's wife. They sent to me for a provisional restoration, and she was due after her 6 months in the temporary to come back and have it done. And I called her and we called her and we called her and she wasn't answering. And so I sent him a message. Actually, I got his wife to talk to her about it. And she goes, oh yeah, well, I was down in Florida and I wasn't able to come in. So they do look good. That is much more of an advantage than a disadvantage to anything else. They don't love having the tooth out. That's a big psychologic problem for any patient. But what they do love is knowing that they can walk out of there that day. And I always take a picture and show them in the picture, or give them a mirror and they go, wow, that looks really good. So when you hear a patient say, wow, when they leave your appointment, then you know they're happy, which means they're usually more committed.
Yeah.
But they do fully understand that it's not going to last forever. And I tell them those temporary posts, they're only rated for 6 months.
How do you prevent material from getting into the surgical site when making the immediate temporary?
That's a great question. And when I did the freehand technique, I didn't inject anything subgingivally there because my bone graft was there. So I just relined my matrix impression and inserted that into the mouth. And so you could see that when I did the freehand technique, it was very short of the little lip on your the shoulder on your temporary abutment. Whereas when I did it with my replica technique, it was not being done in the mouth. So I could squirt down as far as I wanted to. In fact, I got it beyond the little shoulder. If I had wax up to the shoulder, then it would be pretty much perfect there.
Are most cases ridge width stable with bone grafting plus temporization? How many cases have you observed that should have had simultaneous connective tissue grafting during the immediate placement?
So in the first case where I showed the lateral incisor where we did the freehand technique, he didn't have any. If you're placing the implant and I'm not a surgeon, but if you're placing the implant and you're raising a flap because there's congenitally missing tooth. So an orthodontic patient, when they move the teeth, the canine and the incisor away to make space for the lateral, that's done in their teens, and then they got to wait till their mid-20s before they get into tooth. So you lose buccal ridge dimension there. So when you place the implant, ideally what you want to do is the surgeon's going to want to flap it so they can see, but they should bone graft over the buccal bone and before they suture, and that wasn't done in this case. The last case I showed, which was my wife's, she had a bridge there for 20 or 30 years. And when he placed the implant, he flapped it and he placed bone in there, and we got a much nicer result. That was another posterior. That was a 3/6, a lower left first molar. So yeah, if it's deficient, I would prefer the surgeon to bone graft it. I just don't always. These cases sometimes come to me after that's been done. So if you have complete control over the case and you send them out for the implant, say, this is what I want, and this and this and this, and I want bone grafting under the buccal, then they will provide that for us.
Okay, again, how long can the temporary crowns be left in the patient's mouth until final restoration?
They're rated for 6 months. They can go longer. So that's Straumann's temporary abutment, rated for 6 months. The case I showed with the 2 lateral incisors, again, she was congenitally missing. This came from the specialist again, because the dentist sold his practice in the interim. And so we used a variobase abutment because I knew that it would be longer, because I'm not sure if you got it from that from the pictures, but sometimes when you put these in, the screw access hole comes out the buccal surface of the tooth because the surgeon's limited by where the bone is. And the nice thing about using screw retained implant is I can have my access hole coming out the buccal surface, and then I just put composite in that, and I match the shade best I can. Well, so she, with angulated screw channel abutments that we've got now, that corrects that problem. The temporary posts don't come that way, but the final restoration comes that way. It just so happens that because she had very small space between the cuspid and the central incisor, they used a very small diameter Straumann implant that is not yet rated for an angulated screw channel abutment. So she's had those in for over a year, but that's been on a variable-based abutment, not a temporary abutment. So, and I've had to replace the buccal restorations because they stained once in a year.
If a tooth has a porcelain diffused to metal crown on it, can we use that as the provisional or the temporary?
If it's got a PFM on it, can you use that?
I think they're thinking of relining it, you know, picking up the the temporary analog and that kind of stuff.
Yeah, the problem with that is you have to core out the inside to reline it, which it'll break. So that's like the best technique of all that I've seen is where you use the natural tooth. But you can't do that. It's got a crown, you can't do that. It's got an endo access, you can't do it because it'll break. You need a structurally intact tooth. Now, if you have a structurally intact tooth and it's structurally intact that far down, why are we removing it and putting an implant? You can save the tooth, I would think. And that would be my preferred way to go rather than put an implant, I would think.
Okay. We probably have time for just 2 more clinical questions here.
Okay.
When using the natural tooth, is it possible to get some reattachment of soft tissue to cementum?
Yes, I believe there is. I haven't done that, and no one's really done any histology on it because these have all been done in human beings. But if you look at the nature and the quality of the gingival contours, the absence of recession, the maintenance of papillas, that strongly suggests that that you're getting some kind of reattachment of the gingival tissues. If you're not getting reattachment, then you've got bacterial biofilm and the bacterial products. If there's no attachment, no seal, then it's getting right down to bone, and you're going to start to see bone loss and recession and problems like that. And so I believe that because the tissues are so well maintained and they look so healthy afterwards, that you're getting at least some kind of an attachment.
Now, how do you sterilize the natural tooth that is going to be used as the implant crown?
Huh. They didn't say. And again, I've looked for this, soaking in chlorhexidine, hydrogen peroxide, Chu and Tarno's group, they've got a steam cleaner that they use before they reinsert everything else. And there seems to be some good evidence behind the steam cleaner. The chlorhexidine, I've heard it can inhibit fibroblast migration, so it's probably not the best thing to do. I have no idea if these some of these temporary materials, if they absorb, say, peroxide or alcohol or any of those things. I think steam cleaning is probably the best way to do it.
All righty. Well, thank you very much for answering the clinical questions. There's a couple of questions on the recording of the sessions and that. So for those of you that came in late to the webinar, these recordings will be up on our YouTube channel. Should be in 3 or 4 hours. So our YouTube channel is Washington Academy of General Dentistry. If you forget that, go to washingtonagd.org. and you'll be able to click on the YouTube link there. There was a question whether we'll be offering more free CE next week. Yes, we're just putting together our speakers, putting together the registrations. For those of you that are in Washington State that need your opioid and suicide training, be looking on our washingtonagd.org. There will be training on Monday for both of those requirements. We're just getting that finalized, and we should have a full slate of speakers for next week again. Again, this is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. This is Card P Day, so thank you to the Canadian Academy of Restorative Dentistry and Prosthodontics for providing 3 speakers. We'd like to thank Dr. Mark Douglas for a wonderful presentation today. Dr. Douglas, I have to apologize. My internet went out twice during your presentation, but I was happy that I could get back on, and I'm happy that I can actually go in and watch your webinar on YouTube after the fact. You'll see some flyers going by. Some of these speakers have already spoken this week. Just a reminder of who we had presenting for the International Academy of Nathology Day on Monday. Arkansas Academy of General Dentistry was Tuesday. And then you will see also some flyers for the upcoming speakers. I want you to mark down for tomorrow morning, Dr. Manu Karbash is going to come in, and she's going to be talking about systems in your office with COVID-19. She's done a nice research on all kinds of things, from masks to head coverings to disinfectants, etc. So you won't want to miss that, and she will be joining us at 9:30 tomorrow morning. For those of you who are concerned about CE credit, your CE credit will be coming from the University of Washington School of Dentistry CE department. That CE will show up in your inbox in the next 2 to 3 days. AGD members will be reporting your CE credit directly to the Academy of General Dentistry, but that will probably show up in 2 to 3 weeks or more, depending. So I'd like to thank our panelists, Dr. Gary Hayamoto, for running the chat session. I'd like to thank our Executive Director, Valerie Bartoli. Our website master is Dr. Pressett. And thank you for Dr. Herb Edwards for standing by as a panelist today. Dr. Douglas, I can't see if you're still on, but if you're still on, thank you very much. Oh, there we go. I can see now. Thank you very much. You did a great job condensing that all down into that time period.
Thank you very much. That was 3 hours of lecture, and I got it into under 2 hours, which I'm glad I was able to do. And once again, thank you very much for organizing all this. You've not just done that, but you put together a great slate of speakers. I've been an active and enthusiastic participant in most of the sessions that you guys have been putting on. They've been top quality. Thanks once again to you and to Val.
Yo, you're quite welcome. I have one last question for you. This is a personal question. When are the Maple Leafs going to win the Stanley Cup?
Not in my lifetime.
All right. With that, thank you. Our next webinar will be opening up in about 10 minutes here. So we're going to end this one, and we'll get set up for the next one. That's Dr. Kim Parlett. He's up next. So thank you very much.
Thank you, Dr. Mark.
Thank you, Val.
Thank you, Val.
Okay, be well.